Let me start with a quick story. I lived in Bangladesh for a year after graduating college, and I was working with BRAC, the largest NGO in the world and the largest lender of microfinance loans in the country. One of the biggest innovations coming out of Bangladesh was actually microfinance loans. There was a professor of economics, Professor Mohammed Yunus, who ultimately actually won the Nobel Peace Prize for this, but was realizing that women in the rural villages were not eligible or getting any loans. And so he thought, hey, why don't I actually give them these smaller loans and see how we can empower women out of poverty? And what turned out was that only 1 to 2% of women receiving microfinance loans were defaulting, which is really an astounding number. And when we were looking at that, the 1 to 2% were defaulting because they got sick and they couldn't continue working. So we were researching whether a micro health insurance program would create a safety net for those who might get sick. Well, a lot of women signed up since the NGO was a very trusted name and had a lot of trust in the community. But then at the end of the month, women would come back and say, hey, so we actually gave you a good amount of money to pay for the healthcare that we may or may not use. Well, I didn't really use any of the medical care, so can I get the money back? And I still remember being so shocked by that realization of how brainwashed I was by the American system and realizing that like health insurance is actually really kind of counterintuitive. So how do we miss that while it was this whole program was getting designed? So fast forwarding 20 years, and I feel like we've been making similar mistakes in the US healthcare system. We need to really think about including the right people in the design of that innovation, or it's really challenging to address health disparities and inequalities. So this is really where my real story starts. During the COVID-19 pandemic, we saw an exponential rise in telemedicine and remote care. In fact, at UC Davis Health, we converted our entire psychiatry department into a completely virtual clinic in just 3 days. And many other health systems worked at that breakneck speed to make that happen as well. But if you look at this chart, during the pandemic, many, many patients got left behind and many more fell into that digital divide. So what happened to the promise of virtual care and digital health, making healthcare more equitable, more accessible, more inclusive for everybody when you're seeing that the Hispanic population, the Black population, the Asian population are actually putting off annual checkups during the pandemic? Just like the Bangladesh example, there can be a really big gap between the theory and the reality as we charge ahead into the digital age of healthcare. And in order to close that gap, we need to invite more people to the table, a diverse group of people who can identify those blind spots, or else more people are going to get left behind and more people are going to fall into that digital divide as healthcare becomes a lot more technology driven and more digitally driven. So not only do we need more people to be included in these design and ideation sessions, but they also needed to be included in the data itself. So digital inclusion is really key to achieving health equity, and data equity is also a very key component of digital inclusion. So I wanted to give two examples of that, one specifically from our health system and another one around AI. So when we were in the middle of the pandemic, we wanted to target messages to COVID-19 unvaccinated patients because the one size fits all messaging after the first couple rounds was really starting to plateau. So we said, well, how do we use our data, our community engagement, and our faculty and expertise to identify first which groups need to be messaged to in a more targeted, personalized way? So by combining all of those insights, we realized, well, the Black population, the Latinx Hispanic population, the young invincibles, the women of childbearing age, and also the Russian Slavic communities in our catchment areas were a lot lower in vaccination rates compared to baseline. So then we started to craft a lot more personalized messages that could be sent out in a much more tailored way to each and every one of these communities. And we're working with the community to understand what were the psychological barriers and how do we actually address those in a much more targeted way. Well, when we came to the Russian Slavic community, we realized that actually the race and demographic fields in the electronic medical record were not sufficiently capturing that community. So we were not able to message to them because they were not able to be segmented in a precise way. So that's just a really, it's a really important example of how if you're not represented in the data, then naturally you're going to create a lot more biased either algorithms or programs. And we really need to be a lot more inclusive at the data level for every single patient to be represented so that every community gets that personalized touch in healthcare and in digital health. So a related example is the second example around skin cancer and AI. So while fair-skinned people are at the highest risk for contracting skin cancer, the mortality rate actually for Black people are much, much higher. So their 5-year survival rate for the Black population is 73% compared with a 90% for white Americans. So that just shows that what's happening is that the darker pigmented skin is actually harder to detect the skin cancer. And so then the detection is happening a lot later stage of cancer, which is leading to a higher 5-year mortality compared to even the fair skin. And if you think about that from like an AI perspective, a lot of the data sets that we currently have are significantly skewed toward either for computer vision, fair skin, populations, but also just in general, our data sets, are going to have blind spots or significant skews towards certain populations that are more represented. And so it's very important for us to really address health equity from a much more even foundational digital inclusion and digital equity, because that really does set the foundation for a lot of the work that we can do for the various populations to address the health inequities. And so all of this was happening during COVID. And that's right around the time where just about a year ago, we started talking to Amazon about launching a cloud innovation center that's focusing on digital health equity. And I still remember the call where, they're describing the program. It's a co-investment, you're getting unlimited AWS credits, customer obsession, working backwards, tackling the biggest challenges in healthcare and prototyping solutions. And at the end of their presentation, they said, you know what? And all of it's going to be completely open sourced. And I was like, what? So all of it is all going to be open source. And like, yeah, that's the program. We open source everything. The code, the reference architecture, the business requirements documents, the mockups, everything is completely open source because this is a open innovation program by design. And initially, I thought that was really cool. But then I'm also thinking, how the heck am I going to convince our tech transfer office, our faculty, our leadership to buy into that? Well, it wasn't the prettiest ride, but I can tell you our general counsel was actually one of the first ones to understand the value of open innovation. And we were able to announce the Cloud Innovation Center last year at AWS reInvent in November. And today, I actually just want to share some early experiences engaging with the customers in some of the challenges, because ultimately the goal of the Cloud Innovation Center is to bring the right diverse mix of people to the design table early on. And I mean that from patients, the community, the clinicians who are often not early enough at the table for the design, engineers, everybody can really have a role upstream in that innovation process. So in addition to that, we also want to create a more universal framework around digital health equity. So right now, so much of our conversation around digital health equity is around the people. But I think it's very important that we broaden that definition of health equity to include health systems and actually the organizations that are working with the communities. So if you think about it, there's so many health systems that are equally underserved and under-resourced, and they're actually the ones that are often the front line to caring for the patients who have been falling into that digital divide. And if they're not part of that innovation equation, then their patients are not represented in the data, and they're not represented in the design of the next generation of digital technologies and even the new models of care that are open up and activated by digital health. So we need to really keep an open mind and an open aperture for all the people and organizations that need to be included in that innovation process. So I wanted to share some really interesting observations so far because we've engaged with a number of organizations before we officially launch in September of 2022. And one of the most interesting observations is that we noticed how hard it is for people to stay in the customer discovery mindset before jumping straight to the solution to solving that problem. And I think that's a very common culture that even in medicine, we have to be oftentimes reactive and always constantly managing patients and solving problems on the fly. And so when you engage with clinicians or staff, it's natural for the reaction to be, hey, we kind of have a good understanding of the problem. Let's now figure out how to solve it. And I think Einstein's quote really captures the essence of what we're striving for, which is to go deep, really deep, and invest heavily in understanding the problem and the customer before we design the solution. And we're still really pressure testing this model and figuring out, how do we create a viable open innovation framework or an open innovation model that can really unlock value in healthcare and reduce health inequities and health disparities. There's still, a lot of issues that we're working through and figuring out what toolkits even need to be set up and prepared for a lot of the challenge sponsors. For example, we're looking at synthetic data. So what happens if we open source synthetic data based off of real patient data? If we have that kind of capability, could we accelerate research? Could we co-create and co-curate data sets across many different health systems across the country, around the world, to create a much more comprehensive, equitable data set that can really drive, better care and much more equitable care? Would those kind of investments move the needle on digital health equity? So we're still trying to figure a lot of these issues out. But before I share a few examples of our current engagements, I want to come back to that Bangladesh story because there is an ending to that. After we realized that health insurance is really counterintuitive, one of the women actually came up to us and said, well, why don't you make it prepaid like cell phone plans that we have? So back then, there weren't any unlimited text and phone call plans in Bangladesh. It was all prepaid. So we were like, that's like a really interesting observation. So we decided to design a prepaid pregnancy program where pregnant women would pay a small premium right when they got pregnant. And so they knew they were already pregnant. They paid the premium. And then that allowed them to feel really empowered to get all of their prenatal visits since they already paid for it up front. So it really allowed them to do all of the checkups and feel very much empowered and entitled for that care. And we also still had a component of the risk pooling mechanism where we would cover C-sections for the small fraction of women that needed them, since C-sections were very expensive and often can actually put a family in debt for having to do a C-section. So with collecting all the premiums and risk pooling, we were able to cover those C-sections for that select few. So ultimately, the model was shared with other NGOs and it was scaled nationally. And this part was actually the part of achieving, I think, health equity. The best solutions didn't come from the original people that designed the micro health insurance program. In fact, that was designed, that was doomed to fail. But the women were the ones that came up with the idea, and then it was shared openly so that other organizations, even the Ministry of Health, could consider adopting it and scaling it. So it was shared very openly so that many, many more pregnant women could benefit from that program across Bangladesh. And I think, that's really the power of open innovation. That is how open innovation can reduce health disparities and make healthcare so much more equitable and inclusive. So ultimately, the question is, how can we pull that off in the United States and across the globe? So through our Cloud Innovation Center, we're seeing exciting opportunities where teams are coming together to solve some of the biggest, hairiest problems in healthcare. And what's really amazing about this is that when you start out, similar to my own experience, we share with them, look, everything is going to be open source at the end. And you get a similar response, even if we have, let's say, prototype an app, like, is that also going to be open source? And we say, yeah, that's going to be posted on GitHub. And once you overcome that initial reaction, it's amazing to see how much the air in the room changes, because now all of those IP issues that typically, weigh us or prevent us from collaborating so fluidly is completely gone. And it allows these multi-organization, multidisciplinary teams to really invest in the mission, and the mission really becomes front and center. So the first example is we're working with the Society of Thoracic Surgeons to develop an open standard for ePROs, which is electronic patient-reported outcomes for cardiothoracic surgery, so that ultimately it's easier for any patient to be able to report patient-reported outcomes, which is critical for ensuring that digital inclusion, because we need to make sure that all the patients that are receiving cardiothoracic surgery are represented in the data set of what is happening, post-operatively, and when do they need to be managed more carefully or called back in. So a lot of the opportunity is making sure that we're actually broadening the data set of post-operative cardiothoracic surgery patients, which can then drive a lot of new insights and ensuring that the care that we're delivering and receiving is more equitable. And ultimately, because this is going to be open source, we're really starting to create an open standard for electronic patient-reported outcomes that could be used for any other medical association that's interested in it, whether it's the American, College of Surgeons or other organizations. It really offers a much more scalable architecture that allows for potential interoperability if others are using a similar framework. We've also supported a major grant that is looking to increase the rates of lung cancer screening among Black populations by 200%. And at UC Davis Health, again, we have such a large catchment area across California that we really see a lot lower rates of lung cancer screening among Black populations or Hispanic Latinx populations. And how do we really create a model of care and a model of engagement with these patients so that they feel more included and more empowered to come and get the lung cancer screening that they need? And a lot of this also naturally touches on digital literacy and health literacy to ensure that all of those dots are connected for patients to come and get the lung cancer screening that they need. And finally, we're working with the organization Australia to reduce the transmission of HIV to 0% by 2025. So each of these challenges will result in a proof of concept prototype that will be open source for anybody to use. And honestly, we want entrepreneurs, universities, companies, and communities to adopt, enhance, and even scale these solutions globally. If we're releasing data sets, we want organizations to co-contribute to these data sets so that they can grow over time. And ultimately, our goal is to demonstrate that an open innovation ecosystem can exist in healthcare. So as food for thought, wouldn't it be cool if we had a Stack Overflow for healthcare? Like where questions and like healthcare challenges are openly discussed, solutions are shared and they're discussed and they're actually debated and even thumbs up or thumbs down, completely in a transparent forum. We're also, like I said, with synthetic data might be de-identified, it might be cloned and contribute to a larger, more inclusive data set for training the next generation of less biased AI algorithms. So while we're still, very early in the phases of this exciting experiment, it's very clear that we cannot do this alone. For healthcare solutions to be truly inclusive in their design, in the data, in the accessibility, every demographic needs to participate in order to co-develop these solutions together. And again, it's not just every person or every demographic as individuals, but also organizations and health systems of many different sizes and locations. We hope that all of those voices and insights are represented in the Cloud Innovation Center and the work that we're doing. So I'll leave you with a final question. Is health equity and health justice even possible without open innovation? And as we go on this journey, and if you're thinking about these questions, we really encourage you and ask you to consider joining our Cloud Innovation Center through sponsoring challenges or participating in challenges so that we can really work together to reduce health disparities through this open innovation model in healthcare. So thank you very much.